Hi, so today I'm going to be talking about aspirin and a few instances and where it's important to know some details about how it works. So, first to start with a case of a 58-year-old. So, he has crushing substernal chest pain to left arm, and his ECG shows ST elevation in leads 2, 3, and AVF. So, this is a suspected heart attack, right? Because of where it's radiating in the leads. And aspirin is given because it rapidly reduces death, stroke, and future um, heart attacks down by shutting down platelet-driven thrombus propagation, so less occlusions. And the clot is platelet rich, especially early on, so time is money or time is muscle. So stopping the platelets from being sticky or grouping together is life-saving. It can change your whole life. And it prevents damage as soon as possible. Chewed aspirin is the best way to go because it will absorb very quickly in the stomach, obviously. More surface area, faster, right? But why do we use aspirin exactly? Not just because it's magic and we know that it clears up everything, but the mechanism of why it works is it's irreversible platelet COX-1 block. So the platelets have COX-1 to be used in acetylation of the platelet means less thromboxane A2, which means less platelet grouping via the GP2A and 3A activation downstream. So less thromboxane means the clot can't grow as much, so it does less damage overall. And something we'll talk about more down is the mechanism chain of arachidonic acid to COX-1 to prostaglandin H2 to thromboxane A2. So this is really key to how platelets work. Um, irreversible in platelet means irreversible means that platelet has like about a week, or maybe 10 days. But it's reversible in terms of the life of that platelet. So it won't work anymore for that time. And this is important to know in timing because if you are going to have a surgery, you need to stop taking aspirin so you don't bleed out so easily. So the reason they can't, the reason it's irreversible is that red blood cells have a lifetime of about 3 months, 4 months, while platelets themselves have a week, and they do not have nuclei, so they can't just make a new COX enzyme. Mm. The timing is really important, especially in terms of surgery. And if there's active bleeding, you really want to know. But in this case, where he's having a heart attack and his ECG, it implies a right coronary artery occlusion, and that can imply the SA and AV node and the right ventricle. This is important to know because nitroglycerin can be dangerous in the right ventricle infarct. So this is important into leading of why you can not use nitroglycerin, right? It's preload dependent. So we need to take care of the physiology as well as the symptoms so we don't cause future problems. And aspirin is a safe, unless there's active bleeding, like I said, or a true allergy. And talking about that true allergy, in NSTEMI, non-ST elevation, if a patient has a history of anaphylaxis, so reacting bad to aspirin, you can sub with clopidogrel, and it has different mechanism in P2Y12 inhibitor, and this seems like a true allergy case, and it's the best sub for aspirin as a first-line antiplatelet in acute cardiac syndrome, because in NSTEMI, plaque rupture means platelet-rich, non-occlusive thrombus, so it's not as occlusive as a STEMI, like in the last case, but still platelet driven, and the platelets need to be stopped. And heparin itself is not enough. Clopidogrel blocks ADP receptors on platelets to stop signal amplification. Has the same goal but a different molecular target, and it lowers cyclical adenosine monophosphate, so CAMP, CAMP, C. So this is a different path that it takes from aspirin. Mechanisms are important to understand how they work. And in functional groups, aspirin and clopidogrel, they have different structures, but aspirin, generally, the most important part to remember is that aspirin uses acetyl group to the serine amino acid of COX-1. So, different amino acid, but of where it binds to on the platelet. So aspirin makes a covalent bond, and it's a reversible bond to permanently block arachidonic acid access. While clopidogrel uses a thiol to cytosine amino acid on the P2Y12 to make a disulfide bond. And something interesting about this is that both are prodrugs, so their activation is after being ingested. So the thiol group and the acetyl groups are kept for the best time of use. And so this question is more about the mechanism chain, like I mentioned earlier, and timing and for dosage. So which prostanoid synthesis is most inhibited by a low dose aspirin in platelets? So thromboxane A2 is the most controlled in low dose, and that's really what the focus is. But how do you get there is important also, because prostaglandins are not all the same, and in low dose, dose matters, because low dose is targeting COX-1 in the liver, but when you use higher doses than that, endothelium COX and inflammatory prostaglandins are targeted too, and it becomes less selective the more you use per day. This is why baby aspirin is used in cardiology, because it does what it needs to do. It doesn't need to do more. Isn't more is less. Wait, less is more, generally speaking, because you want to turn off the clot signal in platelets, but leave the anti-clot signal in the blood vessels on. And when you overdo it, it does that. So think platelets less sticky, vessels still protected, and that's really what you should remember about aspirin. So thanks.